Hi there, my name is Hallie Van Handel and I am partnering with my co-student nurse Gina Runte to discuss the care of MS. MS is a 76-year-old Caucasian female who, while at home with her son, began experiencing severe shortness of breath and fatigue. Her son brought her to the ED where she was diagnosed with COPD exacerbation and admitted to 3 South. MS's pertinent medical history includes COPD, smoking, and shortness of breath with exertion. She has a known drug allergy to Altase, with which she has experienced an angioedema reaction. MS's pertinent medications include Spiriva and prednisone, which I will discuss in greater detail later. MS maintains a DNR order, and our last recorded set of vitals read temperature 98.8, respiration 16, heart rate 73, blood pressure 143/72, and she was at 92% O2 sat on 2 liters nasal cannula.
I'm going to be explaining COPD, which is chronic obstructive pulmonary disorder. There are 2 types of COPD, which is chronic bronchitis and emphysema. Our patient had emphysema, which is also known as the pink puffer, and I'll be explaining that further. COPD is an abnormal inflammatory response often caused by smoking. This damages the functional unit of the lungs, which is called the alveoli, and it impairs gas exchange. Another telltale sign of emphysema is air being able to get into the lungs but becomes trapped and can't get out. Some signs and symptoms of COPD that we observed in our patient were dyspnea, which is trouble breathing, minimal cough, pink skin, a barrel chest, which is the hyperinflation due to air being trapped in the lungs, decreased breath sounds, and tachypnea, which is fast, shallow breathing. Some risk factors for COPD that our patient had were being over 40 years of age and having a history of smoking.
As discussed, many of MS's symptoms were characteristic of emphysema, as were her associated lab values. When taking a look at her arterial blood gases, MS had a decreased pH level and increased partial pressure of CO2 and a normal bicarbonate level. These values suggest uncompensated respiratory acidosis, which is a common finding in patients with emphysema who are experiencing an acute exacerbation. Additionally, MS's CBC showed a slight increase in her hemoglobin and hematocrit. As a smoker with COPD, MS's body is always searching for ways to obtain more oxygen, so these levels are indicative of a compensatory mechanism. MS's COPD diagnosis was most likely confirmed by spirometry, specifically by an FEV1 and FVC ratio less than 70%. This ratio is a measurement of the amount of air you can forcefully exhale from your lungs. As mentioned earlier, MS used Spiriva as a long-acting inhaled anticholinergic, allowing her a once-daily bronchodilator treatment for the long-term management of her COPD at home. When admitted, MS was prescribed prednisone with the anticipated corticosteroid outcome of reduced lung inflammation and overall alleviation of the acute exacerbation. We also looked to place MS on 2 liters nasal cannula to maintain an O2 sat of 92%. It is important to note that the O2 administration and titration needed to be closely monitored, as we did not want to give high amounts of O2 to a CO2 retainer because it could ultimately decrease her body's stimulation to breathe. We also want to be mindful of other possible O2 complications, including its drying effects on the nasal passages, using humidification if necessary, and repositioning the tubing frequently to prevent skin breakdown. Additionally, it is appropriate to ensure MS has received her flu and pneumonia vaccines to prevent future respiratory illnesses, and also to refer her to a respiratory therapist who may provide specialized chest physiotherapy.
Some other interventions the nurse can teach the patient to do on their own include elevating the head of the bed to make breathing easier, sitting in the tripod position, which is leaning forward to get pressure off of the chest, using incentive spirometer to encourage deep breathing, and also encouraging effective coughing to remove sputum from lungs. Some breathing retraining techniques include huff coughing, pursed lip breathing, and diaphragmatic breathing. Huff coughing is an effective way to encourage diaphragmatic breathing. Have your patient breathe deeply from the diaphragm, hold that breath in for 2 to 3 seconds, and forcefully exhale as if they're fogging up a mirror. Have them exhale this way a couple of times before you have them cough. Pursed lip breathing is a good technique to prolong exhalation, which prevents bronchial collapse and air trapping. In order to do pursed lip breathing, you do exactly what it sounds like. You purse your lips like you're blowing out a birthday candle, and you exhale twice as long as you normally would. Diaphragmatic breathing focuses on using the diaphragm rather than accessory muscles to breathe. This helps the patient inhale as much as they can and slows the respiratory rate. In order to teach your patient how to use diaphragmatic breathing, the best technique is have them lay on their back and put one hand against their chest and one against their stomach. They should breathe so that the hand on their stomach moves outward while the hand on their chest stays as still as possible. Some important education for us to provide to our patient would be smoking cessation because she has a history of smoking. Also, those breathing retraining exercises that I talked about earlier would be great educational points for her. Lastly, education on nutrition could benefit her immensely. COPD patients often have a hard time maintaining good nutritional status because it's difficult for them to eat and breathe simultaneously. Some ways to combat this are letting the patient rest for 30 minutes before and after eating, and also avoiding exercise an hour before and after eating. With that being said, other ways to combat this in the food realm would be providing a high-calorie, high-protein diet and having them eat fewer, more frequent meals so that they don't feel like they're losing their breath as much as they're eating. All of these interventions can help COPD patients maintain a good nutritional status and therefore improve their overall health status.
To sum it all up, according to the research of Bor, Yao, and Raman, future therapeutic treatments for COPD, including those related to tissue oxidative status and stimulation of airway repair, are on the horizon of clinical trial. Successes of such innovative treatment options provide much and exciting hope for those like MS.